Now, to share with you a recent experience that I had in teaching taping classes in Israel, we had a patient who was presented in class by one of the senior physical therapists, and this child had moderate to moderate plus cerebral palsy. We wanted to work not only on her gait, but also on her reaching and her functional grasp, as well as just her ability to use one arm without facilitating the other in a neuro component. When we taped this child, she was 11 and a half, and when we taped her, we not only got a result that I would like, but we got a result even better than what I had expected, which about half the time happens, so that's what makes light elastic taping extremely fun, to work with your patient populations. When we taped this young lady, we were taping her mostly for her right arm patterning in a flexor tone pattern. And so in this pattern, as a clinician, looking at this, you can tell what we would like to do. We would like to inhibit the forearm flexor in order for her to have free range of motion of her hand. We would like to facilitate the forearm extension, and we would like to decrease the bicep activity so that she doesn't hold in this position while we facilitate tricep activity. So those were our goals for the upper extremity and reaching. So initially we measured her so that we could again determine whether or not there was a gain. Whenever you do your assessment in physical therapy, you're going to assess your patient's original state. Otherwise, you don't know if you've made any progress. So we assessed her, and she had about a 45 to 50 degree bend, along with her about a 60 degree wrist flexion. So as we taped, the first pieces of tape that we placed on were for forearm and wrist extension, because her entire extension would start from the fingers. So as we placed this tape on the forearm in exactly the way you saw me place the tape on myself for the removal component when we talked about tape removal, that's exactly what I did. Paper off tension, came through the wrist with her in her available pain-free range of motion, and when I asked her to reach, she initiated the movement from the forearm musculature for wrist extension rather than the forearm musculature for finger extension and then wrist extension. So her component, instead of being pathological in this way, became very nice and smooth in this way. So that was our first component, which was very nice to see, and the therapists in the room were very glad to see that she could have a better movement with the addition of the light elastic tape. We then inhibited the forearm flexors, and that made it even easier for her to bring her hand out. So at that point in time, we went ahead and measured again, and we definitely had more wrist, and we got about 10 degrees more in her elbow extension. Why would we get elbow extension when we've only been working on wrist? If we know neurologically, if we decrease the spasticity and we decrease that information throughout the body, we'll get a better result. So one of the therapists wanted to see, well, if she reaches with her other hand, as she did when we assessed her, when she reached with her opposite hand with the left, she got a flexor component on the right. So we went ahead and taped just those two pieces of tape on the right hand, and then we reassessed her reaching with her left to see if the right would go into a flexor tone pattern. And when she reached with her left, her right arm stayed on the armrest of the chair. So that was really a nice component to see, because we had decreased her neurological input, which is what we would like to do ultimately with all these patients. As we continued the therapy for that day, she came into class and was a demonstration. As we inhibited the bicep and facilitated the tricep, we did them one at a time. We inhibited the bicep, and we got to about 20 degrees of reaching with nice wrist extension, and then she would pull in the fingers. But as long as we did it slowly and step by step, she progressed very, very well. Then we decided, let's go ahead and do synergistic activity with the tricep to facilitate tricep while I inhibit bicep, and she went all the way out to about a -5. So those types of results are what you can expect to see in your patients. It's fun. It makes physical therapy, chiropractic, certified athletic training, Pilates instructors, whoever are the folks wanting to take this course, it makes it clinically applicable to specifically the patient populations that you treat. My athletes have wonderful results, as well as my clinical patients, and the cerebral palsy children obviously are a difficult population to treat. And so to see results with them so quickly is really a treatment adjunct that is so nice because now they go home with that and they have that inhibition or facilitation 24 hours a day, 7 days a week, and you can teach their parents how to tape them. Her father was present and asked if he could learn to tape so that he could have those components of her therapy at home. So it becomes a fun treatment adjunct for us because not only can we see the changes in the clinic, but this is something we can send home with the patients. Their families can learn how to do this. They can learn to do it themselves if they can reach their body part, and they can tape themselves to have a long-lasting input into their muscular system, into the edematous area if we're trying to get rid of swelling, into a connective tissue component if we're trying to reduce pain. So in these ways, our patients can take the treatment and make it their own and actually have results 24 hours a day, 7 days a week, as long as they have the tape placed on them.